Well, hello, everyone. Hopefully you can all hear me well. And I'd just like to say welcome to today's workshop, Clinical Hypnosis in Managing Procedural Pain and Anxiety. Lovely to see so many people here. But before we make an official start, just a couple of housekeeping items I'd like to bring to your attention. Throughout our session today, please keep your microphones muted so that we don't disturb our distinguished speaker and our fellow delegates with background noise. That would be wonderful. And I'm sure this talk will stimulate plenty of questions. So if you do have something that you'd like to ask Dr. Anand, we ask that you kindly type your questions into the chat facility, where we will collate them and ask Dr. Anand to answer them at the end of his presentation. If we run out of time and can't get through them all, Dr. Anand has very kindly agreed to answer them by email, as you can see in the chat. One question I know we get all the time is, can I have a copy of the PowerPoint presentation? And the answer is yes. And again, Dr. Anand has very nicely said that he will give his email address, which is now in the chat, and you can request that from him directly. Also, we have dropped a copy of the notes for this workshop into the chat, and they also have his email address printed on them. Malaysian medical doctors, you are entitled to 1 CPD point by attending this talk. Towards the end of our session today, Julian, our IT guru, will put a slide for you up to scan a QR code. And if you can't scan the QR code, he will also drop a link into the chat for you. We have Adam and Riska here in the background. They've already introduced themselves in the chat. They're here to answer any queries you may have about training with us, and they're very good people to be in contact with. Okay, now it's time to introduce to you today's distinguished speaker. We are very lucky to have Dr. Anand Chandrasekaran with us today, a fellow of the British Society of Clinical Hypnosis. He is an acknowledged expert in the use of clinical hypnosis and procedural pain, and has an inspiring and, yes, hopefully you will find out, a very motivational passion for his subject. An anesthesiologist and critical care consultant at Columbia Asia Hospitals in Klang, Dr. Anand is a pioneer in clinical hypnotherapy who, as I said, has a passion for developing hypnosis as a non-pharmacological approach to managing patients with medical pain, and also as an adjunct in routine anesthesia care. And that includes the use of hypnosedation, hypnoanesthesia, and applying hypnotherapy to patients experiencing preoperative anxiety. I know that this will be a fascinating and informative talk, and that you're looking forward to it as much as I am. So without further ado, it's over to you, Dr. Anand.
Thank you so much, Mr. Peter, for the warm welcome. Let me get this thing running.
Just to share some comment, your camera is a little dark. You can see your background has no light on. Do you have any lights in the area?
Oh,
yeah, fine.
How's it now?
Yeah, camera. You're still a little dark, but it's better than just now. It's better than just now. Yes.
Okay, is my slide can be seen?
Yeah, you can see your slides. Yes.
Okay. All right. So thank you everyone for being here, and thank you, Mr. Peter, for the warm welcome. So I'll make this as quick as possible. I know everyone is busy, but again, if there's questions, I will try to answer. If I can't, I will answer through the email. I may not have all the answers to the questions. Sometimes I have to dig for the answers. So please bear with me. All right, thank you. So our first experience with hypnosis. Many of us had our first experience as a child, when we had our first fall, when we were riding a bicycle, or just fall from when we were learning how to walk. What would most of us do? Of course, we just run to our mother, who administered a healing kiss and the words, "Don't worry, everything will be fine." So the keys was what we call the hypnotic induction, the gateway into a specialized state of consciousness known as focused attention. Mother's words were suggestions for a positive healing outcome that we as a normal human being are totally receptive to. So the outcome is we as a child felt safe and allowed the injuries to be nursed by our mother, knowing that everything will be fine. The confidence that things will be okay gave the child the courage to go through the wound nursing process or any injury. So imagine if you as a medical practitioner can provide the same quality of comfort to your patient, would that make a difference to their care, or at least to you knowing that you have tried to make some difference? So, well, I'm here to share my thoughts on that and my experience with this possibility. And it's for you to make the conclusion for yourself, whether it's worthwhile or not. So what's hypnosis? Hypnosis that is it's an altered state of consciousness that comprises heightened absorption in focal attention, disassociation of peripheral awareness, and enhanced responsiveness to social cues. Pain is the most common symptom in clinical practice. It's a multidimensional experience which includes sensory, discriminative, affective, emotional, cognitive, and behavioral components. It's a huge part, it's a huge component. There is a growing recognition for hypnosis and related techniques in pain management now. Psychological approach to pain control, such as hypnosis, can be highly effective, analgesic. However, it is underused as for now. So I'm going to briefly show you in video. So this video is a procedure where Prof. Mazida is a consultant anesthesiologist in UMMC. So I had the privilege to do a case with her in UMMC. So this is the video of the case.
I think the procedure went quite well. Surgeon did a good job. Hypnosis has a method of anesthesia in helping with local infiltration for the surgery. Worked very well for her simply because I think main component here is the patient is highly motivated. The patient really wanted this process and she cooperated very well, and we had ample of time to prepare her in the ward and down in the OR. Surgeon gave a very good surgical field infiltration with local, and that assisted the process better. And I think she did well. Yeah, she's happy.
Towards the end of the operation, the surgeon was also happy that the patient is very cooperative, and I think this method certainly has a place, especially in patients where they themselves are wanting the method and they believe that it's going to help them relax and whatnot.
So I induced relaxation for her, and since she likes this method called ball of healing energy light, and since she's a Reiki healer, she's very familiar with the concept, and she used that. So basically, there's a principle called utilization principle, encouraging the patient to use whatever resources they have to modify their experience. And she has a very good experience swimming with the dolphins. So that by utilizing that memory, she can disassociate herself from the surgical space.
So when this time I'm concentrating on something else, I'm swimming in the ocean, I'm seeing the waves, I'm listening to the dolphin talking to each other. They have, I have done that in real life, so I can bring it back to my mind, how I was swimming in the Atlantic Ocean.
So she was able to talk with the surgeon, but at the same time, a part of her mind is floating elsewhere. And that allowed her to be relaxed and more comfortable.
The normal anesthesia that you're having, to assist that, I think hypnosis is really very helpful. It's very good as complementary, to the. You have to have something if you're going to have a deep cut into your body. I think, maybe there are people who can do it so that they don't feel anything. I don't know, maybe it's possible. It could be, I don't know. But for me, I could feel a little bit, but I felt with the hypnosis, I was very much no pain compared to last time when I had the injection. I had no hypnosis, but I still had pain. I would encourage it as an assisting, complementary to the normal anesthesia. I think it's very good. It's very helpful. if people want to do it, I would encourage them to do that.
So let's continue with the slides. So there are three main elements in hypnosis: absorption, disassociation, and suggestibility. So I put up this link in this article here. So those who are interested can go and read up further. So in hypnosis, clinical hypnosis produces an altered state of consciousness that places an individual in a state of inner absorption, which reduces an individual's focus of attention to only a few inner realities. Absorption is immersing deeply absorbed into perception, imagination, or an abstract experience. Disassociation is the separating of elements of the mind and behavior. For example, when recalling a memory about our own self, it is similar to a state of dreaming where the subject is both the observer as well as the main character simultaneously. There could be a behavior component in state of unconsciousness, or an experience of sensation of the other parts separated from other parts of the body. So suggestibility simply means that it's referring to the ability of the subject to easily conform to the therapist's direction during the hypnosis process. However, this does not mean that the subject has completely lost his or her self-control. Rather, as the subject is absorbed in the state of hypnosis, the subject's judgment is reserved for a short time. Hypnosis only makes it easier for the subject to accept suggestions and approach a memory which is not achieved by force. Unless there was a concrete suggestion in which that happened during the hypnosis was not remembered and the subject accepts the suggestion, the treatment process can be remembered. So what are the physiological changes that one observes in when someone is doing hypnosis for a patient? A hypnotized person has relaxed muscular tone, reduced respiratory rate, which often falls to a minimum of 13 to 15. Generalized body flush, may or may not have. Reduced activity to outer sensory stimulation. A hypnotized person's eyes are fixed and weakened in appearance. Pupils are dilated. Without hypnotherapist's influence, the hypnotized person lacks emotional arousal and awareness of one's typical sense of self. The hypnotherapist's voice replaces the hypnotized person's inner state words. This seems to compensate for the hypnotized person's disconnect from higher executive function, which corticolimbic point, which I will explain later. Control. The hypnotized person is highly suggestive to the verbal direction embedded in and in the execution of the hypnotic suggestions. Hypnosis causes observable changes in these 5 main areas of the brain. So in these 5 areas, there are papers have been published to support this claim. You can go through the papers. So the first observable changes are consciousness, sleep, and alertness. Hypnosis also causes observable changes in areas imaginary, self-awareness, and motor control. Hypnosis also causes changes in autonomic function, emotion, motivation, impulse control, reward anticipation, and decision-making. And also affects the higher cortical function, which is evidenced in this paper. So there are many theories and evidences in regards to hypnosis, how actually hypnosis works. So it has been started since 1950, has been published in 1950 up to currently now. So in this slide, I just highlighted the main theories in regards to hypnosis. But here we will only discuss the neuroscience evidence of hypnosis, which is just a small part of all these things. So a study by researchers at Stanford University in 2016 considered that what takes place in the brain in general during hypnosis. So this paper is based on that. Functional magnetic resonance imaging, fMRI, was used to observe brain activity in 57 subjects under hypnosis. Changes were observed in 3 specific areas of the brain. First one, reduced connectivity between the dorsolateral prefrontal cortex, which is a part of the executive control network involved in planning and decision making, and the posterior cingulate cortex, which is part of the default mode network that seems to be involved in self-related thinking of one's self. This may be responsible for the disassociation that can occur in hypnosis, and enabling one to place certain events, thoughts, and sensations outside of the self, and thus permits a shift in the cognitive set belief system. The second part is increased connectivity between the dorsolateral prefrontal cortex, which is a part of executive control network involved in planning and decision making, and the insula involved in sensing and regulating autonomic internal body responses. This may be why in hypnosis one has increased control over autonomic response. For example, pain perception, blood flow, temperature, dilatation of pupils. Reduced activity in the dorsolateral cingulate cortex. This part is called salience network, which helps us to notice things that stand out to in our attention. For example, when you see something out of place, hear a strange noise or feel an odd sensation. The dorsolateral cingulate cortex involved in the emotional evaluation of errors and worry, and is active during effortless performance. Reduced activity in this part of the brain may explain the high level of focus that characterizes in hypnosis, and why actions and performance take place effortlessly and less worry in states of hypnosis and absorption. Some call this the flow state. The dorsolateral default mode network, the default mode network is a network of interacting brain regions that is active when a person is not involved in tasks and when thinking, remembering, and daydreaming. The default mode network is not active when a person is involved in goal-oriented tasks or has their attention completely absorbed by something. Hypnosis reduces the activity of default mode network. Reduced activation of the default mode network is also observed in long-term practitioner of meditation, mindfulness. The fact that the brain under hypnosis shows reduced default mode network activity supports the definition of hypnosis as a state of attentional absorption rather than a state where one loses consciousness. Hypnosis shows neural responses similar to spontaneous conceptual thoughts. Perhaps this is why hypnosis can spark creativity and insights for some individual. The frontal areas of the brain regulates a person's ability to concentrate, known as attentional control. Attentional control is closely related to executive functions such as reasoning, problem solving, planning, self-control, and cognitive flexibility. Hypnosis increases the activity of the systems involved in this function, in which are impaired in addiction or ADHD, people suffering from ADHD. So the PET scans of cerebral blood flow in hypnosis shows the involvement of anterior cingulate cortex, which is the ACC, the thalamus, and the pontomesencephalmic brain stem. Hypnosis increases blood flow in the occipital region, which is consistent with the theory that hypnosis decreases cortical arousal. And this is based on the cortical inhibition theory. Increases in mental absorption during hypnosis were associated with increased blood flow in the brain's attentional system. So many people ask me this question: will hypnosis work on everybody? What's the success rate of hypnosis in pain management? This brings me to a topic of hypnotic suggestibility. So in acute or whether chronic pain, hypnosis is not induced or effective in all people. The subject's response to hypnosis and suggestions after hypnosis are different for each individual, and they are temperamental characteristics to a certain degree, which can be termed hypnotic susceptibility or hypnotizability. So in other words, we need to determine whether a person can go through the hypnosis process. So those who have a tendency to easily experience absorption are more hypnotizable than a person with no experience at all. So this conclusion is based on this paper. According to this literature, terms such as hypnotic responsiveness and hypnotic suggestibility are interchangeable. When measuring hypnotic susceptibility, a standardized tool such as the hypnotic induction profile is used. So in patients with acute or chronic pain, those with higher hypnotic suggestibility had a larger reduction in pain after acupuncture. In this research that compares the efficacy of acupuncture with placebo for chronic shoulder pain, and there were no significant difference in the treatment outcome between the two groups. But in both groups, patients with high hypnotic susceptibility showed a significant improvement in pain. Gate control theory was presented in 1965, emphasized the importance of the psychological function in pain control, as in the process of conveying peripheral pain stimulation to the center, the pain is controlled by ascending and descending inhibitory control circuits in the spinal cord. So the brain areas that are activated when pain is experienced are the thalamus, primary somatosensory cortex, secondary somatosensory cortex, insula, forebrain, which is also called the prefrontal cortex, amygdala, and anterior cingulate cortex. These brain areas are called the neuromatrix. Each brain area has different functions. The thalamus, somatosensory cortex 1 and 2, and the posterior parts of the insula are responsible for the sensory discriminatory experience. And while the amygdala and the anterior cingulate cortex and the anterior part of the insula are responsible for the emotional component of pain. Experience is decided by several factors because there is a multi-dimensional characteristics to this pain neuromatrix. When normal people are hypnotized and suggested to feel pain, not only do they experience pain, but the activity of the thalamus, ACC, insula, prefrontal cortex, parietal cortices are increased. The degree of pain and the increase in brain activity were larger when directed to imagine without inducing hypnosis. So when pain was suggested, based on this paper, pain suggested after inducing hypnosis to patients of chronic pain with fibromyalgia, who were already suffering from pain, the pain became more severe than usual. When the patients of chronic pain were hypnotized and suggested for pain to be weak, moderate, or severe, the degree of pain and brain activity changed according to the direction of suggestions, and the degree of change was larger than just imagining without the hypnotic induction. Hypnosis alters the perception of unpleasantness, pain sensation, and pain intensity. Hypnosis not only affects pain intensity, but it also affects the emotional response to pain. In the brain, the ACC part and anterior cingulate cortex is responsible for processing emotion. During hypnosis, when an unpleasantness due to pain is suggested to increase or decrease, the unpleasantness changes in accordance to the suggestions. And the ACC activity also changed accordingly. However, there were no changes in pain intensity and brain activity inducing somatosensory cortex 1 and 2. In contrast, when the pain intensity was suggested to increase or decrease after hypnosis, the somatosensory cortex 1 and 2 activity changed in accordance, but there were no changes in the ACC activity at this point. When hypnosis was induced in fibromyalgia patients, based on this study, relaxation was prescribed also. The degree of pain was reduced compared to the awakened state. And the cerebral blood flow to the bilateral orbitofrontal right thalamus and the left inferior parietal cortex increased, when the cerebral blood flow of the bilateral cingulate cortex decreased. So this finding simply implies that the cortical modulation is involved in pain control effects of hypnosis. And this explains why some patients under hypnosis experience colors. In this study, it concludes that the effect of hypnosis on color perception using PET scan after inducing hypnosis, when colored cards were suggested to be perceived as gray cards and gray cards to be perceived as colored cards, the activity of the lingual gyrus, which is the brain area that processes color, increased or decreased according to the suggestions. This implies that not only with pain experience, but other sensations as well can be controlled, that the activity of the relevant brain area changes according to the suggestions during hypnosis. So, what are the techniques of hypnotherapy? The pain relief effects of hypnosis can be largely divided into two mechanisms: physical relaxation and perceptual alteration or cognitive distraction. Muscle tension often accompanies the occurrence of pain. When there is pain, the painful area is immediately withdrawn, And as muscle tension increases, the pain intensifies. Therefore, when there is an absorption in images or thoughts that arouse just physical relaxation, such as floating or lightness, the muscle becomes relaxed and pain is reduced. So what are the hypnotic strategies? Current hypnotic strategies or methods help individuals to resolve and relieve the unpleasant experience or maladaptive and painful symptoms. Strategies have been shown to be effective in eliminating pain that has been associated with many different types of medical conditions. So the type of suggestion can be used directed, indirectly abolish or diminish experience of pain, associate it with amnesia, time distortion or numbness, replace or substitute pain with other more pleasant sensation, displace pain from one part of the body to another part, associate pain with age regression that will return the individual to an earlier time when pain is not experienced, disassociate it from the rest of the person's body. And the seventh is reinterpret pain as sensation of warmth and comfort. What this simply means that when a practitioner wants to use hypnosis as pain care, these areas should be considered in their suggestions. So not necessarily all, depending on situation. Different techniques should be used in alteration of perception depending on the hypnotic susceptibility of the patient. People with low hypnotic susceptibility respond better to distraction techniques, which concentrate on competing sensation in other parts of the body, which does not feel the pain. Imaginative suggestions can be used on those who are not induced into hypnosis due to low hypnotic susceptibility. This situation has the patient requires the patient to imagine, while suggestions are given without inducing hypnosis. For patients with high hypnotic susceptibility, suggestions of numbness in the painful regions of the body can be used. For example, a feeling of receiving an analgesic injection or anesthesia at the dentist's office is recalled, and it is then suggested that this feeling spreads to the painful area. Also suggesting that the pain is like a bad liquid that flows out of the body and can flow out of that body, suggesting of separating the painful area from the body, and suggesting that the patient can separate from the body in order to separate from the pain. Again, type of patient is very important. The temperature metaphor is useful and commonly used technique that I use. It is effective when hypnotic susceptibility is more than moderate. Images of ice, cold water, lumps of ice, or cold water coming down the mountain, something like that can be used to suggest that the painful area is becoming gradually colder, or in contrast, images of the sun, warm bath, warm blanket can be used to suggest that the painful area is becoming warmer. Pain sensation, temperature sensation, all pass through the lateral spinal thalamic tract, which supports the usefulness of this technique. This technique helps the patient to transform pain signals. There are a few principles in the images metaphor used in pain relief. Preparing the patient for reasonable expectation is very important. First, pain may continue for the patient, but the patient should be able to feel the difference between the pain signal itself and the arousal discomfort, and then be able to filter the hurt out of the pain. Second, through hypnosis, the patient should have the experience where pain signal is transformed into something less uncomfortable. So before hypnosis, it was perhaps either pain or no pain, but through hypnosis, the pain can be transformed into a different perception by competing sensations such as tingling, numbness, warmth, or coolness. Finally, the patient should not fight the pain. Fighting with the pain is actually concentrating more on the pain. So anxiety and depression or other feeling intensifies and physical tensions increase, which leads to more pain. So this expectation needs to be clear with the patient. So what I'm trying to say here is hypnosis does not make the person feel no pain. Rather, it substitutes, rather than feeling pain, they might feel discomfort, cold, numbness, tingling, changing of perception. So briefly, techniques that can be used in acute pain relief. Deepening. So induction and deepening, this technique normally are used for acute pain relief when someone is highly suggestible. Can start with any breathing calming induction method. For example, every time faster and faster, breathing faster, 20, my pain will decrease, faster, 19, my pain will decrease, faster and faster to 18. So this method is only suitable for someone who has high who's highly hypnotizable. After achieving relatively strong analgesia in certain parts of the body based on the earlier technique, normally I aim to mentally transfer the analgesia to another part of the body, for instance, from the hands to the abdomen or the back, or this way gradually and progressively reduces the global pain and suffering. When a state of higher or light or deeper relaxation is achieved through different techniques, the patient is trained on how to interpret the feeling of pain coming from a specific place of the body and to transform it slowly from feeling pain to a feeling of different nature. For example, light or medium tension, moderate pressure, beneficial warmth or cold sensation of the area. So when using focus suggestion, patients are taught that after major medical problems have ruled out and being under the care of a physician, then the pain which continues becomes chronic pain. Like any other feeling in the body, it is a signal. Hunger is a signal to eat, fatigue is a signal to sleep, and pain is a signal to do self-hypnosis so that the pain does not increase in severity. For example, people with chronic back pain fear that their pain will quickly become severe and it will not be able to continue their work or perform other important tasks. So it's the duty of the provider to explain to patients that self-hypnosis should decrease pain and may not make it completely disappear. When pain is thought of as being bad or unhelpful, it is easier to become irritated and want to ignore it. Using this cognitive reframe of attending to pain as a signal helps to teach patients how to pay attention to their own pain in different ways and may increase self-efficacy because they learn that they can manage their pain better. So example suggestions, you can find this in this in the document that I think we have printed, sent to you, types of suggestions. So basically this is after inducing relaxation state, to induce the suggestion of hands are warm, hands are cold, those words. So I'm going to show you another video on how I've done a case under hypnosis in the OR. So this patient had a very small minor procedure, extremely minor, normally can be done under local anesthesia. However, this patient was so extremely agitated and he requested general anesthesia, but there were some issues in his general anesthesia. So hence, I offered hypnosis plus local anesthesia. He agreed, and let's see the video. So let's continue the slides. Self-hypnosis is important to relieve habitual pain through suggestions and imagination in acute, mostly in chronic pain. But I use self-hypnosis in acute pain also. The hypnotic state must be frequently induced to extend the pain reduction during everyday life. However, it is practically impossible for any therapist to induce hypnosis several times a day. So application of self-hypnosis is very crucial here. Nevertheless, a problem present in pain treatment is that most people do not practice self-hypnosis. So if self-hypnosis is difficult, we try to induce relaxation method. Could be used as an alternative induction method with relaxation and concentration. It is helpful to explain examples of patient of the association between muscle tension and pain before actually inducing hypnosis, and also the relationship between pain and concentrating on the pain. It takes time. You need to spend time talking to them. What are limitations of hypnosis in pain care? Hypnosis is only effective method for acute and chronic pain, for most acute and chronic pain. However, there are a few limitations. First, it is only effective in patients with high hypnotic susceptibility. The anticipated analgesic effect is not achieved in low to moderate hypnotized patient. Therefore, measuring the eye roll sign, which is a scale in a hypnotic induction method profiling, is helpful in identifying patients who can experience the analgesic effect through hypnosis. So the eye roll sign has 5 grades ranging from 0 to 4. Usually patients who are 3 to 4 are highly hypnotizable. Then I will use this method in my anesthesia. In most acute pain patients who do not have any psychological disorders, for example, depression or severe anxiety, so when the eye sign roll is high, it is most likely that the actual hypnotizable rate score is actually higher. Second, there can be psychiatric complication in chronic pain patients. However, in chronic pain patients, the actual hypnotizability score are not consistent with eye roll sign. Instead, they are usually lower, since many of them are suffering from major depressive disorder, anxiety, some to a certain extent drug abuse, personality changes, dependency, regression. So therefore, in chronic pain, the effect hypnosis can be limited to a certain extent, but it's an option that should be offered to patients, I believe. However, there are cases where patients with chronic pain have severe psychological problems at the same time. Feeling of anger, guilt are considered to be psychological reasons. These patients require psychodynamic therapy, which is not in the range of pain medicine. So experienced psychodynamic hypnotherapists may be required, or even psychologists required. And in these cases, cost can be a problem sometimes, or accessibility. So most chronic patients have already economic difficulties from the cost of their treatment from their original condition, even before reaching psychodynamic therapy or any psychological approach. However, despite such limitation, there are frequent clinical cases where hypnotic treatment has become a tool for the permanent cure of acute pain, chronic pain patients. All right. This video shares perception of patient, his opinion, his view, his experience in a case is pure hypnosis. It was a minor procedure which can be normally done under local, but this patient, again same, he requested for GA, but his ECG showed some changes, and based on the risk and circumstances, he agreed for this, and he shares his experience here.
My name is Vishal. So I got admitted this morning for a small bump on my eyelid, and I consulted Dr. Siba and the anesthetist behind the phone here, Dr. Anand. It was a pleasant experience. Just to make it quick and short, before the procedure, I went to the clinic downstairs, consulted Dr. Siba, and they brought me into the operation theatre. And there, Dr. Anand, he asked me some questions. Questions like, why was this tattoo in your hand? I mean, why did I put this tattoo in my hand? So I answered, it's me and my wife, and there's a globe there. And why? Because I want to travel around the world, and I've been to multiple countries as well. And after that, he was practicing a few movements in my hand. Maybe he just wanted to see if I was a bit stable or what so. Then he also asked me to mention things that I like going to the beaches, my feet on the sand, the sound of wind and things like that. And within a minute or two so, I was traveling a little bit. It was very digital hospitalized. I was on boxes, and I was there, but I was traveling. Yeah, like lights, boxes. A couple of minutes later, I woke up, and there was another person here just checking my BP and stuff, and said, yes, I was definitely very feared. I have anxiety. Especially when it comes to needles, medicines, doctors, it's not my thing. So definitely I was very stressed out. My heart pumped fast, and I wasn't at ease. Calm after, I just don't know how I became calm. But after that beach, you asked me to think about the beach noise, the sand noises, then I became more calm. Previously, I've had taken the gas before. I don't know if it's general anesthesia when I dislocated my knee. However, that one, as soon as they put that, whatever that face thing is called, you just knocks you off, you just sleep. This one, it took me like on a ride for a while. I was like in some other dimension, and when I woke up, everything was done. So it was two different experiences. But personally, if it's a major surgery, then I would prefer going into general anesthetic. But minor ones, like what I went through, I think this is excellent.
So conclusion, hypnosis is a natural phenomenon which is genetically inherent in most in humans. Or hypnotic treatment can be compared to a computer after clicking a program's icon to activate it, where the install program initially was not used at all. This program then becomes hypnotizability or suggestibility, and the method to activate is called to induce hypnosis. Hypnosis induction is pretty simple, and the basic is concentration and immersion of the mind. In a hypnotic state, various functional changes of the brain are achieved according to suggestions and imaginations, and through this, pain can be controlled. So if clinicians who deal with patients in pain, who has experience in pain treatment, learn hypnosis, perhaps it can be helpful for patients. It has its limitation, of course, but with proper strategies and expectation, it has great potential for patients. So thank you. If you have any questions, or comments, feel free to email me.
Thank you very much. We do have we have had a couple of questions dropped into the chat. So the first one is from Dr. Aziza. Does level of education influence hypnosis suggestibility? It's an interesting question.
Sorry, I didn't hear that.
Does the level of education influence hypnosis suggestibility?
Hypnosis, yeah, level of agitation. From my experience, what I've noticed is the more agitated they are, the easier for me to induce them into hypnotic state, because their concentration is scattered. So the moment I ask them to focus on something, it's easy for them to focus on something rather than having a scattered mindset. So the moment they focus on something, the relaxation flows very fast. But that does not mean it has to be the only method. If it fails, you need to have plan B, plan C, plan whatever plan. But it works to calm the patient down. And once they are calm, then you can deploy whatever treatment, whatever you think you need to do.
Thank you.
Sorry, just to add on to that, to assess a patient's hypnotizability rate does not depend whether he or she is agitated. So based on the literature, it's based on hypnotic profile induction, the scoring system. So there are many scoring systems. So the most common one is eye roll sign. You can refer to the slides later. The literatures are there.
Also, it's the level of education, the education level of your client, of your patient. Does that have an effect?
Sorry, level of agitation?
Education, yes.
Level of education. Okay, all right. Yes. But I think a person who is not so educated, but if you take time to explain to them what is there to be achieved, what's the expectation, most of them are okay. I never had, of course, someone who's highly educated, someone who does their research, reads a lot, is so much easier. You spend less time talking to them. But that does not mean if a person who's not highly educated, you don't offer this option. So always offer the option, explanation, consent taking, If despite all this explanation, they still don't agree to you, they don't understand, then plan B.
Okay, thank you. And Mohammed Ramat says or asks, did you manipulate, trigger the conscious and unconscious mind of the patient during the event so that the patient was able to divert their thought from negative to positive perceptions?
Let me try to understand the question. I don't understand the question. Unconscious and subconscious mind to get a patient to go to the subconscious so that they can change perception.
Yeah, from the negative perception of pain to a positive perception.
All right. So this changing perception is based on CBT tool. Basically getting the patient to understand they do not need to suffer the experience of pain. So getting them to understand that shifts from perception of pain to I can manage the pain, rather than pain to no pain. So most people expect pain to no pain. So changing that perception, pain to something I can manage and I can carry on in my life. I can allow the doctors to do these things. So is there a conscious, subconscious? If you try to explain to a patient subconscious, conscious, it's going to be very difficult for them to understand because they are in pain. So make things easy for them. For example, if someone is in pain, so I will tell them, do you want to suffer this pain or do you want to help us? We help you to help yourself with pain. So of course that's helpful for them.
Okay. And another question here from Gary. You will need an induction, or do you need an induction with deepening first before the dissociation suggestions? So if you're dissociating, do we need to do an induction and a deepener?
It all varies from patient to patient, situation to situation. Of course, in chronic pain, you have to take them slow. Relaxation first, deepening, and then dissociation, it comes slowly. But when it comes to acute pain, it varies in strategy. So there is no proper one rule that fits for all patients. So in other words, you have to be able to be very flexible at a point of time. Just have in mind, these are the steps, but you can always jump the sequence.
Lovely. And Jamie asks, hello, I'd like to ask whether hypnosis can be only done by anesthesiologist or can it be done by other medical professionals as well? And also, what are your thoughts, interesting question here, on what are your thoughts on using hypnosis to manage pain and anxiety in patients with special needs such as autism, ADHD?
So there are two components to this question. Number one is, can pain be practiced by non-anesthetists? I think any doctors is given a privilege to manage a person's pain. So for example, if you go to a labor ward, a pregnant mother who is undergoing labor, most of the time the midwives or the doctors will tell you, will tell the mothers, take a deep breath, pay attention to the breath, breathe slowly, breathe regularly. So that's a form of distraction. It's a form of managing pain. So doctors, nurses, anyone can learn this art because it is it's not invasive and doesn't use drugs. Yes, non-anesthetists can. So the second question, I think that I'm not qualified to answer the question simply because it falls in the realm of psychiatry, psychologists, ADHD. It is a bit slightly complex. From what I've read from the literatures, answer is yes, it's possible, but you have to go through deeper into that. Yeah.
Thank you. Interesting one from Hector. How important are motivation and expectation from the patient to obtain success? They can have doubts. How do you increase confidence in the process?
Very good question. Motivation, expectation is crucially important in this step. So that needs to be aligned with what you can deliver. If it is not aligned, then you will fail. If it's aligned, most of the time it works very well. So second part of the question was, what do I do to negate the doubt? I don't do anything. It's up to the patient to settle the doubt, because they already made a commitment to themselves that they're going to participate in the process. And if the doubt appears, I just facilitate them to manage the doubt, actually talk to the doubt. So in the sense that if they feel it's not going to work, then it's their responsibility. It becomes their, the reason it's not working because it's their fault. So instead of taking the blame and the fault is not working on the therapist, turn it around. Most of the time, they will be able to manage the doubt themselves. You just have to give them time, the room needed for them to negotiate with themselves.
Lovely. And I've got a question here. Does asking patients to focus on taking a deep breath during local anesthesia help to reduce the needle pricking pain? Interesting. What are the ways that you do to reduce this procedural pain perception of the patients? I'll just throw in, yesterday I had some dental procedure carried out, just some deep cleaning, and my way of dealing with the needle prick pain is when I know the needle's going in, I just breathe out. But Dr. Anand, it's your question.
All right, this patient to focus on deep breath, yes, it helps, of course it helps, but we need to explain to them how it helps. So if they have the knowledge how it helps, it actually works better instead of them just doing the breathing method. Because when they do the deep breathing method, they do feel the needle going through in. So we have to explain to them it's a process where we are converting the sensation of pain to something else, whether warm or cooling, or just let them, help them to as they have deep breathing, they start to daydream, something like that. Again, expectation need to be explained to them. What are the best ways to reduce procedural pain perception of the patient? The best approach is always communication. The first step that needs to be established. If you communicate your intention and you understand the patient's or the client's the whole thing about pain, 50% of the problem solved, or in fact, sometimes be higher. And whatever we do is just to distract their perception from pain to an inner absorption state where calmness, daydreaming. So the best way is communication, the first stage. In our practice, consent taking. So that's where we do all this.
Interesting. So I was just thinking, as you're talking, this fits in with also something that Mohammed Ramat has asked: is does empower communication during the procedure divert the focus of the patient during that procedure? And from my personal experience, when you're just about to get an injection and someone says sharp scratch, they're focusing you on pain. So my personal perception is also the language is important. Dr. Anand, what's your idea?
Very true. Because in the beginning, when I started, I used to do these mistakes. I'll tell the patient, okay, you're going to feel this needle. So the moment you mention needle, the picture of needle comes into their perception. Needle means sharp, sharp means pain. So the choice of words is very important. So whether the surgeon is, so now I've learned that over the years, once the patient is relaxed, do not use negative words. There has been a literature published on this. Negative words does induce pain. So instead of telling you're going to feel this injection, you say, I'm going to give you something to numb this area, and it's going to have better effect to make you more comfortable. It's the same thing. You're giving injection. Instead of telling I'm going to give injection, I'm going to give you something that works better to make you more comfortable. Of course, before they go through the procedure, I've already warmed them up, prepared them. You're going to feel this comfortable solution going through your body. You may have some discomfort. Is going to be converted to a sensation of flowing like a river. Make them practice that first. Once they are already practiced, then they go through the procedure, it becomes smoother, very easy. Most of the time, they don't even remember the needle going through in. And once the LA goes in, done.
Thank you. And Jonathan, you say, what does it take to be trained in inducing hypnosis, and what are the avenues? Are there courses for formal training? Well, certainly, if Adam or Riska contact you, we can send you details about the training that we hold as well. And another question here. From Hector, an image is worth more than 1,000 words. Don't you think that showing the patient videos of patient success with hypnosis could increase their chances of cooperation?
Very good suggestion. Actually, it works. Unfortunately, there's certain limitations to that. Sharing patient's videos to another patient is may not be suitable because patient's rights. There's bigger issue to that. So sharing videos with patients can be a bit difficult. But those videos that you saw just now, those are simple videos. I do share with them, some patients. Again, conversation. The first level is conversation. Why they want this to work. So if you come with a frame frame of saying why this has to work for you, they will formulate their perception. This has to work for me because blah 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 blah. Then it negates the doubt part.
And just, I've got a couple more small questions here, but before we do that, Malaysian medical doctors, I think, Julian, could you put up the QR code so that you can scan this for to get your CPD point? And also, I think you just dropped in something into the chat, into the screen. That's brilliant, and also into the chat. So just whilst everyone's got that up, we've got something here that somebody's saying, thank you for informative sharing. May I know, do you need to do any hypnotherapy sessions with the patient first before doing the hypnosis procedure?
Answer is yes, yes. So normally, if a case is posted to me on my anesthesia list, I will see the patient in the ward or even before they get admitted in the clinic. I will talk to them whether this is suitable for them, whether they want to try this approach. And if they're okay with that, so that's where I explain everything, the consent taking. If they're okay with that, then on the day of admission, depending on the type of surgery, on the day of admission, several hours, maybe about 4 or 5 hours before the surgery, I will practice these methods with them, get them go through the whole process. And then when they come down to the OR, again, a very fast one, and then doing the surgery itself. So in short, to answer your question, answer is yes, we need to do this practice and then train them self-hypnosis methods.
And one final question from Mohammed Ramat again. Does the hypnosis concept differ from mindfulness, or is it a similar thing?
Sorry, I didn't get the question. The hypnosis different from mindfulness?
Yes, is hypnosis different from mindfulness, or are they similar?
I think Mr. Peter, I think you're the best to answer this question.
The very easy answer to that then is, I think they're both the same. It's the same state of mind. It's just how we use them. When I first learned about mindfulness, I realized as a hypnotherapist, I've been doing basically that for quite a long time without realizing. So, so that would be my answer to that. The same state of mind, we do different things.
Yes, I agree to that.
Okay, and I think we're going to have, well, we've got to finish there, I'm afraid, because we're almost at the end. Thank you, Dr. Tranam, for a truly amazing talk. I'm sure everyone here has found it as insightful and as informative as I have. And we have plenty to think about, and certainly as you go back to your own practices, hopefully some of you will be considering bringing hypnotherapy into your approach to patient care. And also just a thank you as well to Julian and Shia, who've been silently keeping things running smoothly in the background, and also again to Riska and to Adam from the sales team who have been there, and you can talk to them with regard to any ideas if you were looking to train. And a big thank you to all of you for attending and allowing us to share some of the passion that we have for the amazing approach that we call clinical hypnotherapy. So thank you very much, everyone. And we truly look forward to seeing you again at some more of our workshops. Thank you. And good morning, good afternoon, good evening, whatever part of the world you're in today, because I know we're all the way across the globe. So been lovely to be with you today. And Dr. Anand, again, thank you very, very much.
Thank you, Mr. Peter. Thank you everyone for being here.